Hi, everyone. This is Dr. Guffey. I wanted to talk today a bit about teamwork, communication, and collaboration, especially within the realm of an acute care practice. You will be working alongside many strong personalities, as that is often the case in personalities that choose to work in acute care. And navigating those relationships and communication can sometimes be difficult, and they're skills that are not always easy to learn and not always easy to teach. And so we're going to be talking about that a bit today and looking at a few ways to communicate within the acute care environment. We're going to identify some of the values and attitudes within an acute care environment and kind of talk a bit about navigating those. We'll talk about the concept of mutual respect, whether or not some of us have different values or judgments or ideas about patient care. There will always need to be a respectful environment in order to discuss those values. One of the examples that I always think of is having a group of several different intensive care unit providers, including physicians and nurse practitioners. Absolutely, there might be different practice histories and backgrounds. Perhaps one of the physicians has experience in a specific mode of ventilation, and that is their mode of ventilation of choice. And that is absolutely fine. But when you get the group together, they may have different ideas that can bounce off one another regarding care for very specific patients. Sometimes there's a little bit of conflict in that, but the best way to deal with that generally is having that mutual respect and communication strategy whereby you can discuss that in a collegial environment. There may be some disagreements, and one of my directors in the past always told us, absolutely, behind closed doors, the provider group may have differences of opinion based on a specific patient case, but out in the unit, in front of other service lines and in front of our other colleagues from different specialties, we must present a united front. And that has always stuck with me, and continue to work toward that in any specialty or subspecialty that I have worked in. And I would hope for you all to do the same. Collaboration will build trust. There is definitely going to be some difficult cases, especially within acute care and pediatrics. And so having that collaboration, having that trust between one another is extremely important working in this environment. Acute care settings, they're so full of noises, sights, smells, lights, machines. Even to this day, if I walk into a different subspecialty environment, it is definitely overwhelming or can be overwhelming. So we're faced with taking care of critically ill children, and then we're also trying to figure out how to navigate a new role for those of you that are obviously in school right now. You're navigating the transition from a bedside nurse to a provider in an acute care environment. That can be very difficult, especially for those of you that chose to work within your previous practice site. When that happens, transitioning from nurse to advanced provider has a very different role, and some of the other nurses or service lines may not see you in the same way anymore. And so there can be a difficult transition between the respectful nature of you then becoming more of a leader than you were in the bedside role. Some of that has to be navigated. In addition, you'll have varying nurse practitioners and physicians with different backgrounds, practices, and experience, like I discussed previously. And we're not only working to take care of the child and to make the child and caregivers comfortable and better, right? Our goal is to improve their health. We're also coordinating this multidisciplinary team. This is why we've talked about over the years the difficulty that we sometimes have having no true medical home for some of these very complex patients. And so within the acute care environment, oftentimes we're getting just a little snapshot of the child's whole life. And this is why we're so grateful to our primary care providers, because of course our children that we're caring for will also have hopefully a primary care provider that's managing that whole entirety of them, rather than just the little snapshots that we may come upon in whatever department or area that we're working. So cultures, we talk about this so much throughout all of our classes and lectures here at Baylor. The culture that we come from, the culture of the hospital, the culture of the acute care environment, the clinic where you're going to be working perhaps in the bone marrow unit or in an outpatient specialty clinic. That culture has to promote a culture of respect. There has to be respect both between you and the families, between the families and you, between you and your medical staff, and so on and so forth. The team-based debriefing and having individual debriefing has been shown to improve when there is some rocks in the boat, which there probably likely will be in acute care environments. And so having that culture where you have the freedom and the ability to have perhaps your medical assistant come to you and talk to you about an interaction, where the medical assistant is not afraid of voicing concerns, perhaps, or it may be a day where unknowingly you raise your voice or you speak in a different tone than you normally have. And that is absolutely going to happen. And there is nothing necessarily wrong with that, but it has to be a culture whereby there can be some discussion about that and some resolution without the undertone of fear, because fear will do no one any good within the acute care environment. Mentorship is extremely important in this unit. Week 1, we're looking at collaboration, communication, and transition in the role from bedside nurse to nurse practitioner, and having a mentor and somebody that guides you in that transition is very important. As well as there needs to be some level of communication training. It's not something that we all are experts at. Communication, unfortunately, is the lead to much of the demise of society in general, and poor communication techniques do not benefit anyone within an acute care environment. Things like meetings and workshops and educational activities aren't always the top on people's fun things to do list. However, it is very beneficial if groups can experience those together. It helps with team bonding. Things like journal club within a hematology oncology practice are very good, and can even be informal in some ways, where you might meet in someone's home and discuss a pertinent journal and then have a bit of time for team building as well. That is why we work so hard on collaboration and communication. This is just a general picture of what the ICU can look like on any given day. The cardiac ICU, perhaps, or the medical ICU. Walking into this, if you think about that from the point of never having seen something like this before, which is going to be the majority of the patients that we care for in the ICU, as well as their parents, although it is quote unquote normal to those of us that have been in the ICU for years, this is completely overwhelming to look at. So just take a second and think about the perspective of those that we'll be caring for, as well as the multidisciplinary team that maybe hasn't been in this type of an environment before. This is the us. This is what we all actually love. And those of us that have worked in the ICU and these critically high settings, such as the ER, ICU, and other units that take these types of patients that are on many different infusions on, different machines. It can be overwhelming. We like it. This is part of what we love, and we need people that love that, and it becomes familiar to us. However, we have to step back always and remember that walking into seeing your child attached to all of these things can be extremely overwhelming. Consistent in our routines, whether it be our rounding routine, our communication with our assistants at the hospitals or in the clinics is very important. That consistency that we've talked about in your physical exam routine and your routine when you come into the bedside in the morning and you're checking your ambu bag to make sure that it is connected to oxygen. You're checking the suction to make sure that it works. You're looking at your monitor to make sure that you are comfortable with the alarm limits. All of that will then transition into your practice where you get to clinic in the morning and you're looking over the patients that you may be seeing that day in clinic and determining in your mind which ones may have more acute issues and which may not. You come to the ICU in the morning, working on a critical care shift as a nurse practitioner, and you are prioritizing your day. Yes, there's always going to be notes and paperwork involved, but what do you need to be doing first? How can you make it through that day? And having a relative routine in that, although that routine may very easily get thrown out, when you have something happen, which is another thing that those of us in acute care thrive on, you need to make sure to have some mechanism of that routine in place so that things don't get missed along the way. Teamwork and working together, again, is not something that's innate to many of us, especially those of us with strong personalities. Different backgrounds all come and meld within the acute care environment. However, coming back to the fact that we all chose healthcare and then specifically pediatric healthcare for a reason is extremely important. We have to look at each team member with their purpose, why for them, this is us for them and what their perspectives are. And then realizing that, again, whether or not we may have different practice recommendations or not, we're all in this together for the good of the child and the family that is surrounding that child. Communication theories are prevalent when you do searches on the internet. There's absolutely initial communication theories going back many, many years ago that were linear, saying that I'm talking and so I'm the sender, and then that's a linear relationship to you, the recipient. However, more recently, there are so many barriers that communication theorists have recognized, including what's going on around me. Not only if I'm the one delivering the message, what's going on around me. Am I at home working on a lecture for you all, and perhaps my dog starts barking, or I'm watching for the door to make sure that the UPS package that my daughter wants gets delivered, or we are having extremely hot weather and I'm so hot sitting here. All of these are barriers, right? In addition to the fact that I'm delivering this to you. And if you're in an environment where you're online as well, you may be doing, other things while you're listening to this, which may be okay, but that is a bit of a distraction. In addition to the fact that if we're talking face to face and we're in an acute care environment, there are going to be noises around us. We would definitely have interruptions, which can absolutely cause a problem in communication. And so there's context within that communication theory. What kind of a place are we in? What is the relationship of what's going on? That is all very important. This diagram talks about those distractions that can occur, and also rather than linear, now more circular communication seems to absolutely be more efficient, whereby, yes, I am the one perhaps sending the message, but then you are also involved in that, processing that, and then we're either repeating or we're talking about things socially and culturally, and then we come to an agreed upon circular relationship and meaning of our conversation, whether or not it's something that can be simple, all the way up to the very acute planning perhaps of a patient's chemotherapy. This is something that we need to think about more of as a circular process than linear as it was in the past. Barriers we've already touched on a little bit. We can come to some relationships with assumptions. Not to pick on surgeons, but absolutely surgeons are known to have a bit of a more brusque personality in general. And studies have shown that the people that choose to be surgeons, especially cardiac surgeons or neurosurgeons, generally have a personality type which tends to not be as social, right? So I always have to remind myself when working with the neurosurgeons, although I love them, they aren't as socially adept as some other people are. And so the assumption when you're perhaps speaking to one of the surgeons is that they don't want to be there, or they don't want to hear this information about the patient. Oftentimes, however, that's not the case. It may be just perhaps the way that they're presenting themselves. And so the fear in that communication pattern will have to be something that you deal with as well in acute care. Calling a consult that you're not completely comfortable calling is one of those assumptions, and the expectations can be extremely fear-provoking. Calling cardiology to me was always one of the hardest things that I felt like I had to do, because I had a very hard time verbalizing to the cardiologist exactly what a rhythm looked like. Of course, that was in the old days before they could pull up the cardiac monitors at home like they can now. But that was always something that was concerning to me. The expectation was that they were going to be annoyed with me, when that in fact may not have been the case. And the same can then happen when you're presenting rounds. Perhaps you're presenting a patient in front of a large group, and absolutely there can be a barrier just in that the expectation is that I'm going to say something wrong, or they're not going to listen to me. That anxiety can then be, seen in obviously the way that you present that patient, or the way that you speak to a consult. Stereotyping unfortunately exists. Of course, labeling exists as well, and bias or pre-existing bias will exist. One of the things that I think about a lot is with the pediatric obesity work that I've done, there is a bias that surrounds obesity. And so there has to be a thought, an actual communication pattern that exists, whereby somebody that has pediatric obesity understands that my bias does not influence the communication that I have with them and their parents, as it should with all of the things that we have, that we will deal with in acute care. Positive communication techniques, again, unfortunately, are not something that's just inept. We were not all born learning and knowing how to speak exactly within all situations. Sometimes I wish we were. Having empathy, we do know, is very important. That empathy needs to be real, and it needs to be produced as such. Obviously I can't judge if someone is truly empathetic or not, but having active listening, making eye contact, are all things that are very important. Within the ICU or a busy clinic, specialty clinic environment, it's best always, if you can, when you're seeing patients or when you're talking to the family of a critically ill child, to sit. That shows that you are more empathetic, and that you're taking time to make eye contact with them, rather than charting on Epic or looking at your laptop while you're talking with them. Clarifying meanings, whether it be to somebody that you're working with as a partner, or to a family member or a child, is very important as well. And then the body language that we use. Are we seemingly hurried? Are we crossing our arms, standing over the child and family, rather than sitting down, making eye contact and having an open stance with them? As we've talked about with Dr. Peck as well, motivational interviewing and the way that we talk from that standpoint, obtaining data is going to be very important. See if we can get these videos to work here.
Surgery. Hey, I have a patient for you. I'm sorry, who's calling? No, this is Kathy from the ED. This is for Miss Uni. Is it the new consult? Yeah. This is Miss Uni. Okay, what's the MRI? 77856. Okay. So she's a 30-year-old female, history of ectopic pregnancy. Wait, why are you calling in? So she already consult gyne? No, so she has appendicitis actually on CT. So this is for appendicitis and not an ectopic pregnancy? Yes. She's got a history of ectopic years ago. She's not even pregnant here. Okay, where is she? Acute 6A. Okay, thanks.
So that example there talks about how, first, when I call, I'm not even introducing myself, right? Like, I'm not telling the person that I'm calling who I am or what I need. So It's just obviously not to pick on the ED at all, but the ED is generally a very busy environment that many of y'all will work in at some point. And you have on your mind, obviously, that this person had an ectopic pregnancy in the past, but that's not what she's here for now. So you're putting this information out there, but the surgeon needs to know exactly what you're calling them for at that time. So that's just a good example of what that phone call can go like in a busy environment. Whereas if you take a second to kind of put your thoughts together before you call, it would have been a lot smoother than that. So let's watch then the good one here.
My name is Kathy. I'm one of the residents in the ED. I'm calling about a new consult for appendicitis.
Okay, what's the MRN?
77856.
Okay, what's the story?
So the patient's last name is Mooney, and they're in 6A. And this is a 30-year-old female, history of ectopic pregnancy, status post left self-hysterectomy. She's here with 2 days of right lower quadrant abdominal pain, as well as vomiting. And she's been febrile to 102 here in the ED. Her white count's 23. She's had a negative urine pregnancy test and a normal bedside pelvic ultrasound. Her CT shows appendicitis.
Okay.
So we've given her morphine for pain and started her on IV fluids and antibiotics. Anything else you want to add?
No, sounds like she's being managed appropriately now. We'll come see her.
Okay. And what's your name?
Morrison?
Okay. And when will you be here?
Give me about 20 minutes.
Okay, great. Thank you so much. Okay.
Perfect, right? One of the things that I will probably harp on you a little bit in your acute care SOAP notes and in your presentations of patients is that many of these kiddos, like we have talked about, will have multiple issues, but punchline first is a general good rule when you're calling a consult or you're delivering a patient in rounds or to us in your presentations. So, for example, I'm taking care of a kiddo that has BPD and is at home on a trach and ventilator at night and has retinopathy of prematurity and maybe has a VP shunt in place, but they're here for constipation, then I need to start with that when I'm calling the ICU or calling the transitional care unit to drop the patient off. I'm not going to start with this long laundry list of problems because who I'm speaking with doesn't have the context of all of that. I need to let them know first and foremost what the patient's most current problem is, and then can always follow along with that. If I called GI to let them know that this kiddo was in the hospital, I wouldn't start off with, this is a kiddo on a ventilator at night. They're going to immediately have an idea or a bias that I'm not calling the right person, or they have no idea why I'm contacting them, right? So I might start off with the fact that this kiddo is a 2-year-old with a very difficult past medical history who is here with constipation. And then I would give them a little bit more detail, including the fact that they were a premature infant who has chronic lung disease and requires tracheostomy and ventilator support. That way you're giving them that information first that tells you why you need them or reaching out to them specifically, and then giving them a bit more context. I know that many of y'all have heard of SBAR, so let's watch another quick video on how this is very well done.
Hi, Dr. Feldman? Yes, this is Amy from 2 West. I've been taking care of Miss Everett. Well, she's an 82-year-old woman. She was admitted 3 days ago with DVT. She's on heparin, telemetry, and oxygen. She's been alert and pleasant with no problems other than urinary retention, and she has a Foley in place. But tonight she appeared confused. She's awake and oriented to person, but she thinks that she's at her aunt's house and that Ronald Reagan is president. Yeah. Well, no, I checked with her nurse from the last few nights and confirmed that she doesn't sundown and she's normally very sharp. Her heart rate has increased to 110. Her blood pressure is down to 110/60. Yeah, her systolic usually runs 150. Yes. Her temperature is 37 Celsius. She looks pale, but not uncomfortable. Her coax studies are within the parameters and her blood gas is normal. All other AM labs are normal. but she's not putting out much urine, and it looks cloudy to me. I'm worried about her. I think she needs to be seen. Want me to order some labs? Maybe send her urine for culture?
Yes, sounds like she could be getting septic. Send a urinalysis with culture, chemistries, and a CBC. Thanks for calling. I'm on my way, but I need to know if there are any changes immediately.
So that's a very clear discussion, right? You saw how at the beginning the physician was putting away her dishes in the kitchen, and then the nurse really gave some good information that got her to sit down at her computer and start writing some of the things down, because she was clear in her communication with why she was anxious versus just calling and saying, "Hi, this is Carrie. I want you to know that I think this patient's septic." That's not generally the best way to call to start off. Give a little bit of the SBAR background, the situation first. So that punchline first, like we talked about, but then giving a bit more information to let them know what your specific concern is. And note that she also had in her mind what was different. Current vital signs, yes, were not terrible if you heard the sound of them. However, when you saw or heard what her blood pressure usually ran, then it becomes a bit more concerning.
Hi, Dr.
So just this schematic was very good regarding that high quality patient-centered communication that we must have within the acute care environment. Just so amazing to think about the things that are going on even during a normal conversation within our acute care practice. And this was a great article that I will share with you guys as well, just discussing how models can work and can look, all with the vein of having a high quality discussion within an acute care place. Outcomes, again, for the child and for the family are going to be our most important goal, those good outcomes. Mutual respect we talked about before, but I just wanted to have a good picture from one of my mission trips that kind of shows how everybody is making eye contact. Everybody's standing together around the child to have a discussion about this kiddo that just got back from cardiac surgery. There's a lot of people there. There are a lot of machines there. I would, myself personally wants that monitor off the bed and wants to start straightening out lines. But in the midst of that, of all those little tasks, we need to stop and make eye contact with the anesthesiologist or the CRNA who's giving report on the kiddo, and have a mutual understanding and communication pattern respectfully before we take over and assume care. Collaboration, also very, very important, obviously within acute care, working together towards that common goal of the child and family being well taken care of. Again, just like communication, working together as a healthy team is not something that can unfortunately just happen. I think everyone has probably experienced some level of poor team communication or even toxicity within the workplace. And the goal as we move into advanced practice is to absolutely not be a part of that. So again, we're framing ourselves, just our own practice and our own reflection into being a safe space so that we can reflect on ourselves and our own behavior and actions, as well have the people that we work closely with be able to experience those good reflections of ourselves and changes that we make within ourselves, but also be able to let us know if there is something that seems conflicting, or if something came across in a wrong way or an abrupt way, which it ultimately will end up happening once in a while to most of us. We'll learn how to learn from our own failures, and as hard as that is, between the transition of practice from bedside nurse to nurse practitioner, it's going to happen. And then we'll also want to just span those cultural boundaries to where my biases, perhaps, and my culture and background does not inhibit me from providing excellent care. And then I am very open to others' cultural background and experiences as well. Here's a great picture of just collaboration and an innovation within healthcare. This was in one of the hospitals that I continue to still do mission trips with. I just thought this picture was so First of all, genius for them to make wheelchairs out of plastic lawn furniture, out of the need to do so, right? Not as expensive as an actual wheelchair. Probably a little bit more comfortable for some people as well, but just wanted to throw that in there. Within our interprofessional relationships as well, we have a responsibility and accountability to be partners, and we have that responsibility and accountability to help make the team cohesive. We do not want to be the one wheel that is the bad wheel within the team. We want to, as advanced practice nurses, model very professional behavior, mutual respect, and collaboration, as we had talked about. Having efficiency in our communication, and then working towards goal sharing and value sharing, even if we all come with different values, is so very important. Here's the references for this. And again, I will share articles. Please let me know if you guys have any questions.